Where shared decision-making fails. Shared decision-making between the provider and patient is one of 4 pillars of patient engagement. It is a basic tenet of patient-centered care. This is where healthcare decisions come from a collaborative process between patients and their doctors. According to this model, patients are empowered to express their opinions, preferences, and values, which the doctor is supposed to integrate into their treatment recommendations. This is found in healthcare policy worldwide. In reality, many patients have to deal with barriers that can cancel out any scope for patient-centered care. Addressing these challenges is vital for any kind of patient engagement to work. Time constraints and power imbalance. Doctors often have limited consultation time, making meaningful discussions difficult. In the UK, in the public system, NHS, this is around 10 minutes, 30 minutes in the private sector, but much of this is, I'm sorry to say, rubbish, involving not much substance, a lot of small talk and padding the consultation out. More on this in a future article. Our colleague bureaucracy from Turkey wrote an article for this blog stating that doctors in Turkey are under pressure to see up to 250 patients a day. In an 8-hour day, this would be 1 minute 55 seconds with each patient. Imagine the waiting room. Short appointments lead to rushed decisions. There is little time for patients to be appropriately informed about their treatment options. Where is the patient-centered care? Furthermore, a power imbalance exists in many doctor-patient relationships. Some doctors adopt a paternalistic, talking down to you approach, assuming they know best without fully considering the patient's perspective. In cultures, this is what is expected in a clinical consultation. Patients may not feel comfortable asking questions or being their own advocates out of fear of being dismissed or judged. Therefore, this is not a collaboration. And, despite policy rhetoric, this is how healthcare is delivered for the majority of people. Implicit bias and healthcare disparities. People who feel marginalized often experience disparities in shared decision-making. Factors such as socioeconomic status, race, and gender can influence how patients are heard and treated. Implicit bias leads to some groups receiving less personalized care, feeling dismissed, or being excluded from decisions relating to their own health. Reducing these biases would require systemic change, and this starts with the acknowledgement from the healthcare providers that this is happening. This is difficult when it is so embedded into the subconscious. Health literacy. Understanding one's health condition is essential for proper treatment adherence and self-care. However, healthcare systems often assume a high level of health literacy, leading to the following communication gaps. Assumed high literacy levels. Many medical documents use complex terminology that is difficult for patients with limited education to understand. Cultural and language barriers. Speakers of languages other than the mainstream language, for example English in the UK, and culturally diverse individuals may struggle to understand medical information. This has an immediate effect on health outcomes, such as a lack of compliance to spoken health advice, such as lifestyle or prescribed medication regimes. Lack of personalized education. Generic one-size-fits-all health materials fail to address individual patient concerns, limiting their effectiveness. In clinical waiting rooms around the world, written materials for patients gather dust from one year to the next. Tailored education based on a patient's condition, learning style and background improves engagement and health outcomes. Do health professionals have the appetite to provide this? Technology should enhance patient engagement, yet many barriers prevent it being used effectively. First, there is the digital divide. Even in today's tech-driven, tech-enabled world, older people with low incomes, people in remote rural areas often lack internet access or have little to no digital literacy. This limits their ability to benefit from e-health services. In many countries, the political agenda is to push all public services to be delivered electronically. Secondly, for people who are digitally literate, there is often unfavorable user experiences. Many health apps and portals are difficult to navigate, discouraging consistent use. UX design is all well and good, but UX testing is of utmost importance before deploying a health technology and afterwards. Then there are privacy concerns. Patients worry about data security. This can lead to user reluctance to adopt digital health tools. Trust and participation can be forged through simple communication, the truth, about security measures. Emotional and psychological support can be lacking in health professional patient interactions. This is because of poor, joined-up thinking. Mental and emotional health is often seen as separate from physical biomedical health. It can also be because of the patient's reticence to seek mental health advice and support due to stigma, which can be governed by cultural rules. For those that do disclose mental health concerns, they may find referral help is inaccessible due to long wait times or shortages in providers. This can cause fragmented care, being caught up in the machinery of bureaucracy, and then there is the patient's burden, individually bearing the responsibility of coordinating their own care. Waiting lists in any health service kills any possibility of patient engagement. In the US, there is also the financial burden, which is a significant barrier for many patients to the entire notion of empowerment. Just under 10% of Americans have no insurance. Half of Americans of working age struggle to afford health care, and over 1/3 are in medical debt. Again, health literacy, or in this case insurance literacy, is the issue, where people in the USA routinely receive unclear medical bills, and unpicking complex insurance policies, deductibles, co-pays, coverage limitations, and being put under unexpected financial strain. In UK, as we are more likely to move towards a two-tiered healthcare system, this will be a shock to the system. To reiterate, all of these barriers erode and drown meaningful engagement. We have to wonder, who exactly is this empowered, engaged patient that policymakers around the world love to describe? I ask because it seems like a great number of people are not. True patient-centered healthcare needs systemic improvements in education, digital access, emotional support, care coordination, and financial transparency. Addressing these challenges will create a better, more equitable system that creates more optimal conditions for patient health professional collaboration and improving health outcomes. This can be extended to patient institution or organization collaboration. Thank you for listening. Originally written by Mark Gibson, Boston, USA, November 2024.